everyone. Good afternoon, everyone. Welcome to this special session with the clinical problem solvers. It's my honor to introduce my program who will be presenting today. I am Bettina. I'm part of the clinical problem solvers and I'm part of the case review committee. So if you have ever submitted a case, you might have seen my email address in there. But yeah, I am a PGY2 from Elmhurst Hospital, and I'm very, very happy that I have some of my colleagues here and my program director um, to present a wonderful case today. So yeah.
Thank you, Bettina, for organizing this episode and invited your residency program. I think I can pass the mic from everyone from the program to say hi for us.
I can start. My name is Sylvia. I'm a second year resident. I'm the case presenter for today, and I'm excited to be here. So, nice to meet everyone.
Can go next. I'm George. I'm one of the chief residents at Elmhurst. So nice to meet everyone, and thank you for having us here.
I'm Dan. I'm one of the other chief residents, and it's a pleasure to be here.
I'm Julie Kanevsky. Everyone calls me Dr. K. I'm the program director at Elmhurst and really psyched to be here for the second time. I had a lot of fun last time and back for more.
Thank you all for being here. At the end, we can ask for the program a few questions. And so if you have any question and anything that you want to know, please put in the chat that I will try to track. And we can start with the case. We're going to have Jasip and Johnson discussing the case. And thank you so much, Aaron, for being scribing and Jillian for doing the teaching points. I think we can start with the whiteboard.
Okay. If we're ready, I can start. So there's going to be 7 aliquots in the case today. So we can start. So we have a 41-year-old man who presents with new onset papilledema and worsening headaches. So what do we think about that?
Yeah, thank you, Sylvia, for presenting today. So we're seeing that we have a middle-aged male presenting with papilledema and worsening headache. Whenever I hear the combination of these two, I would think of some like a component of increased intracranial pressure. Initially, one of the things that can be also happening, just like this person is having a hypertensive emergency, let's say, as well. So it could be, I would start initially trying to exclude a central nervous system problem that's happening, either like whether, as we mentioned, hypertensive emergency, anything that can cause an increased intracranial pressure, hemorrhage, any trauma that happened or preceded his symptoms, any space-occupying lesion as well, for example. What do you think, Jazz?
No, I think that was well done. Honestly, I was hoping for not to be a neuro case, but I guess that's how the cards always fall for me. So, yeah, I think the main two things here that are important is time course, which is unknown right now. And like for example, papilledema and headaches for the last few weeks is different than a papilledema and headaches for the last couple of hours or days, right? But I think I don't have much to add. I think that's important, and the other thing that's important is it the unilateral? Is it just one eye? Or is it two eyes? Usually papillema is two eyes, but not always. And then what I'm thinking about is there a space occupying lesion like you mentioned, that's causing maybe an obstruction that's raising the ICP, and then or is there something that's impairing the drainage of the CSF fluid? And then is there something that's impairing the absorption of CSF fluid? Those are all different mechanisms that have different etiologies. But I think right now it'll be kind of far-fetched to pin it to one etiology just because we have just a one liner. And I think it was a really great start to just kind of thinking how you want to think about this case. But I think it'll be really interesting to see how the HPI shapes up.
Those are all great points. Sorry, continue. So if we're all ready, we can move on to the next aliquot. So let me take you guys back a little bit prior to him presenting for our admission. So he came in 4 months prior to a different ED, and at that time he was complaining about headaches, specifically right frontal. The headache radiated to the temporal and to the occipital regions. He described it as pressure-like, 8 to 9 out of 10. It wasn't improving in any with any pain medications he was using. He said he was waking up most mornings very early with the headaches. At that time, he denied any nausea, any vomiting, any photophobia, any phonophobia, any blurry vision, any weakness or numbness. And that at that ED visit 4 months ago, he had a CT head, which was unremarkable, was then discharged home. A month after that ED visit, he then presented again to a different ED complaining about, again, severe right-sided headaches and also a witnessed focal seizure. At that time, was admitted again, and then had CT head done again, had an MRI brain, had an LP done, and all of those were unremarkable. The second visit, he was then discharged with Keppra. He was following up outpatient with neurology for the persistent headaches and recurrent seizures, and also because he wasn't also taking his medications as prescribed. And so the day he was admitted, he was sent in from neuroclinic. So on my admission, he was sent in from neuroclinic due to worsening headaches associated with a right eye papilledema. So what do we think now?
Wow, that's a lot to digest and a lot that has happened to the patient. So he's been having all this going on for like around 4 months. So we're kind of in the like subacute to chronic time course. And so we know now that it is a unilateral uh, it's a unilateral headache. So that could Okay, so unilateral. And it's not so when you started talking or describing more about the headache, I was thinking about the red flags that we learned about in med school. For example, not responding to medications, like the headache waking the patient up from sleep. All these are considered kind of like red flags. And that really it made me think more of a space occupying lesion. And then when he said CT head was negative, I was like, okay, CT head doesn't really tell us much. We need a brain MRI, but now a brain MRI, a lumbar puncture is negative. So I don't know what exactly to make out of this part. Um, Trying to think like especially now that he's having focal seizures. I'm not sure if we need to do like a repeat imaging, a different modality of imaging, something related to the vessels, for example, happening because like the focality in this doesn't really need to be in the brain parenchyma itself. It can be also in the vessels, meninges. So I'm not sure exactly. What are your thoughts, Jazz?
Yeah, you're doing great, Sosan. I think this is a very challenging case. I think it's challenging because like when you hear a case that just started and we have seven aliquots and aliquot 2, the MRI and LP are normal, we're up for a big challenge here. So you did really great in trying to like kind of seeing like what things could be possible. And I think I'm equally as confused as you are, I would say. And when I'm confused, I like to step back and say, okay, what are we dealing with? And I think this is a subacute, so 4 months of subacute, progressive, morning predominant, what it seemed like pressure-like unilateral headache with papilledema. Um, and the fact that the CT, MRI, and LP are normal hints towards like it kind of rules out an obstructive mass, right? That we would have seen that on the CT and MRI. It also significantly reduces the possibility of meningitis. So you can have meningitis lead to these type of symptoms, but the time course does not fit for your typical meningitis, and even for your like indolent organisms, the LP and MRI would have shown. Now, this one, especially the LP, would have shown something. So the things that ask us our questions is there something that could have eluded the workup that the team has already done that needs a specialized MRI or imaging study and that's still causing pressure to build up? And one of the things is a venous clot, right? So a cerebrovenous sinus thrombosis, could that have been leading to these headaches? And usually those are unilateral headaches. But we don't really hear any symptoms or suggestions such as any hypercoagulable risk factors for this patient. So the social history would be key. Is this an individual that had some type of sinus or ear infections recently? So those are the things, or do they take any supplements? The other thing is, to be honest with you, son, the fact that like the MRI and the LP was normal, um, I honestly, I would really ask this patient any new herbal supplements or any medications this patient was started on. Do they have history of bipolar? Were they titrated on their lithium recently? And the reason why I'm saying that is, could this all be idiopathic intracranial hypertension? Um, so I think these are the things that are like going through my mind. There are other things like rare things like could there be like a dural arterial venous fistula that's forming this and do you need like a specialized like MRA or MRV to diagnose it? But I think it's a little too early to be thinking about that. I think we need a little bit more history. And so far, very interesting case, and I'm just kicking myself. That's another neuro case. So really great so far. Sylvia, back to you.
I love all the points you guys are bringing up because this was also challenging to us too. So I completely understand where you're coming from. So the next aliquot, regarding his past medical history, he had no past medical history, no known. For medications, he was on magnesium oxide and was recently switched from his Keppra to oxcarbazepine. Family history wise, his sister has migraines. For social history, he denies any smoking, any alcohol use, any recreational drug use. He works as a car salesman. He initially used to live in a endemic area to mosquitoes, originally from the Philippines, and immigrated to America 12 years ago. Regarding allergies, he has no allergies. And then we can move on to vitals. For vital signs, temperature was 97.9 Fahrenheit, heart rate was 83, with a blood pressure of 151 over 101, respiratory rate was 20, and he was saturating 100% on room air. Regarding his physical exam, he was a middle-aged man laying uncomfortably in bed, sorry. HENT, he had an anecteric sclera with perla and moist mucous membranes. Cardiovascular wise, regular rate rhythm, normal S1, S2, no murmurs, no rubs, no gallop. Palm wise, clear lungs, no wheezes, no rales, no rhonchi. Abdominal wise, non-active bowel sounds, soft, non-tender, non-distended. And then neuro wise, he was ANO times 3. He had this mild right lower facial droop with a hyperreflexia of his left lower extremity, but the rest of the cranial nerves were intact. He had gross strength intact of the bilateral upper and lower extremities, 5 out of 5, with sensation also intact. No lower extremity edema on extremities, and warm peripheral extremities as well. So what do we think?
Excellent. And then the only thing I wanted to clarify, I might have missed it. I'm sorry. You said that he's from Philippines, but when's the last time you visited Philippines?
He hasn't traveled outside of the country since he moved 12 years ago. So he hasn't been to the Philippines since 12 years ago.
Gotcha. Okay. All right. Thank you. So, um, so I guess like the new signal, I guess, is the fact that we have objective focal neural findings with the mild facial droop and the hyperreflexia in I think it was the left lower extremity, which now tells me if we want to localize this, it's either like the right hemispheric upper motor neuron process, and you know, which is interesting because the MRI was normal. And yeah, the blood pressure is elevated, but it's not high enough in my opinion, I don't think it's high enough to explain the papilledema via malignant hypertension. So yes, sure, he's a little bit hypertensive, but I feel like my blood pressure is 155 right now, and I'm not having papilledema. So I think the blood pressure is probably now less likely leading to the papilledema. And typically, from what I remember, is that malignant hypertension leading to papilledema is usually almost always bilateral, which and it can present unilaterally, but usually that's like the illness script I have for malignant hypertension. So I think right now I would love to anchor and say that, oh, he's from an endemic part of mosquitoes. Could this be West Nile virus, especially now with like this, other, but he hasn't traveled there for 12 years. It doesn't make any sense. I think that's just his background history right now for now. I still would not really shift the needle far from like, could there be something in the arterial system, whether it's, a malformation or a venous sinus clot that could be explaining this. Um, Based off the exam, it seems like there is like this potential upper motor neuron signs, but we don't see anything on the MRI, which is why I'm suspicious for a possible arterial or venous etiology that was missed on your regular MRI. Um, and then if that's all negative, I feel like, could this be secondary intracranial hypertension? Patients who are from countries like Asia, like I can tell you, my family loves to taking like turmeric and other things that may not be FDA approved. So I would really want to ask this patient that, like, are you taking any herbal supplements or regimens that are from the Philippines that we are not aware of that may be leading to these symptoms? But so, son, I'll turn it to you to fill in any gaps.
Well, I don't think so. There's anything. You said everything. That's really good. Um, as you mentioned, there's an objective data of like we have some like localizing symptoms and everything. I'm trying to think about, okay, the blood pressure, as you mentioned, it's not that high to explain that, and it's not bilateral. I feel like it's giving a hint maybe that that body is under stress, and we can either think, for example, as you mentioned, like secondary causes of hypertension. But I feel like at this moment, I'm trying to think if to include or like consult ophthalmology and to take a greater look at the eye and see if there is anything that or any clue that can help us with that. I feel like these are like my initial thoughts, and maybe with the initial set of labs, this can give us a hint if there's like a systemic disease going on that can explain this. For example, a vasculitis or any other autoimmune disease, maybe. Yeah. Back to you, Sylvia.
Great discussion. Honestly, I'm loving this. This is amazing. Okay, so we can move on to the next aliquot. We can go through our labs now, hematology wise. For CBC on white count, his WBC was 10.3. His hemoglobin was 15.6 with a platelet of 201. For chemistry wise, his sodium was 140. His potassium was 4 with a chloride of 102. Bicarb of 25, BUN of 12, creatinine of 0.99, glucose of 94, calcium of 9.4, magnesium of 2, EGFR of 98. And then AST was 26 with an ALT of 44, ALK of 74, and an albumin of 3.7. So what do we think about these labs?
Okay, so far, as a first pass, looking at the labs, I don't see any evidence, for example, of end organ damage happening either at the kidneys or the liver. CBC looks good so far. Like I'm not seeing evidence, for example, of anemia of chronic disease so far. The hemoglobin is not considered elevated, for example, for me to think of polycythemia vera and it causes like thrombosis kind of picture or anything from that sort. So yeah, I feel like this is getting more and more challenging for me. What do you think, Jazz?
Honestly, the only thing I'll add is this tells me that this is less likely to be a systemic process, and this is isolated to the nervous system. And it's clearly staying contained in that area and it's not like leading to any end organ damage or any other systemic response. Like I would be also impressed. Like if I were to guess, I would say this, even if we were to check inflammatory markers, it would probably be normal. So other than that, yeah, I'm ready for the next aliquot.
Okay, let's move on to the next aliquot. So given his physical examination findings, a stroke code was called an arrival. He had a CTA, head and neck done, which showed no intracranial arterial occlusion or significant stenosis in his arteries of the head and neck. He also had a CT head done showing mild hydrocephalus. And then after that, he also got an MRI brain, which showed leptomeningeal enhancement in the right temporal region and focal cortical enhancement posteriorly in the right temporal lobe. He also had an MRI cervical and thoracic spine showing leptomeningeal enhancement involving the visualized portion of the cerebellum, the brainstem, the cervical and thoracic cord. So, what are you guys' thoughts now?
Okay, so we're kind of removed the vascular cause aside, and now when we're talking about the leptomeningeal enhancement, the first thing that comes to mind reflexively is TB, especially that the patient also comes from an endemic area. So that really, this is the first thing that comes to mind. I know there's a list of differential diagnosis for like leptomeningeal enhancement. One is TB, other can, I think sometimes maybe sarcoid do that, but I'm not seeing any hints about that. I'm not sure if some other autoimmune etiologies that, or what other infectious agents can cause, but I know there's a list for that. Maybe Jazz can help me this part.
Yeah, this is why neuro is just so complex and challenging. So you did a good job. I think I agree with Vale in the chat that your encephalomyelitis, I can't even say it, encephalomyelitis schema has been activated. Like this, that's a lot of, first of all, that's a lot of leptomeningeal enhancement. Like all the way from basically the brain all the way down into the brainstem and then the C spine and the T spine. So kudos to the team for not just stopping at the brain MRI and also getting the C and T spine. I agree with you. I think, to be honest with you, from the Philippines and this slow, indolent process, how could you not think about tuberculosis meningitis? Now, the LP is interesting, but I think this process was specifically in the CS, like in the portions where like it was causing more of an increased ICP and causing this hydrocephalus and this subacute month on head, like, and without causing an overt like meningitis picture first. And it seems like now he might be presenting that way, especially with the leptomeningeal enhancement. And like it's often missed early, it could be falsely normal with the LP and MRI. Um, but I think just to be kind of like closing the loop here, or like just making sure we don't miss anything. I think fungal meningitis, like Cryptococcus, should also be on the list, especially considering it's notorious for causing an increased ICP. Fun fact: the fungi itself are just very big, and they just kind of decrease the clearance of CSF, and that builds up and it causes an increased ICP. And then, unfortunately, the other ones that you don't want to miss is cancer. So leptomeningeal carcinomatosis or lymphoma is also on the differential. I think a 40-year-old male, you kind of they're in like that prime age where lymphoma leukemias can happen. But like I said in the earlier aliquot, the labs being reassuring tells us that this is probably less likely to be systemic, and he doesn't fit the illness script to be like CNS lymphoma. So I think cytology is something that we would definitely send, and maybe even a flow off the CSF. But I guess, Sosan, I'll ask you, if you're taking care of this patient, what are you ordering next? What are you doing after seeing this MRI finding?
I feel like I'll do a lumbar puncture and send a bunch of like a whole panel for like infectious causes and autoimmune panel for other like autoimmune diseases as well. And as you mentioned, cytology, if those weren't sent before in the first lumbar puncture that he had. So I feel like that's what I'm gonna do. Uh, maybe,
Yeah,
oh,
No, go on.
I'm not sure if at this stage I would, for example, look for um I'm not sure if keeping like a malignancy in mind, I wouldn't like pan CT scan him right now or anything. I feel like I'm gonna start with just like trying to focus more on the central nervous system and do the lumbar puncture. I'm not sure, honestly.
No, I think you're 100% correct. The labs don't really suggest like a systemic process anywhere, right? So like I think a pan scan would only be I think maybe if like you're concerned for TB, you can get a CT chest just to see is there nodules or pulmonary TB that this came from. But remember, TB can do anything it wants, right? The lungs can be completely normal, and this patient may just have neuro TB. But yeah, I think infectious workup off the it's interesting that we don't have the repeat LP, and I'll be very curious to see what that is. I would expect lymphocytes, but even in early TB meningitis patients, you can still have a neutrophilic response. So I think I would expect the new LP or the repeat LP to be very noticeable, in my opinion. But I'd be very surprised if it's normal this time around. But now I think the social history of the patient makes more sense. And then, in addition to the LP, the infectious workup, I would be sending a pretty broad bacterial, fungal, and TB workup for this patient. But yeah, I agree. I think the only thing I'll add, Sosan, is I guess neural sarcoidosis, but he doesn't fit the demographic, and then also does not fit the progression. Usually neurosarcoidosis would have had other clues, like lungs, skin, eyes. Doesn't typically lead to papilledema. It usually leads to other scleritis types of pictures. But it could be subtle. But that's what I'm thinking right now. It's really, really cool case so far. Sylvia?
I'm glad you guys are coming up with amazing differentials and an amazing workup too. So we can move on to the next aliquot. So when he was admitted to us, he had a repeat LP, and I can tell you the lab. So on the repeat LP, he had opening pressure of 37 with normal values between 10 to 25. He had nucleated cells of 0 with normal being between 0 to 5, a protein of 38 with normal being less than 40, glucose of 41 with normal being 40 to 70, and an ADA of less than 1. We also obtained CSF HIV, Cryptococcus, Toxoplasma, IgM and IgG, syphilis, Lyme, mosquito, Babesia, Ehrlichia, ANCA, MOG, quantiferin, Sjogren, NMO, and oligoclonal bands, which were all negative. We obtained cytology, which showed rare mononucleated cells and foam cells. We also got CSF gram stain and culture. Culture showed no growth. The CSF gram stain showed no PMN, no organism seen, and CSF fungus/India ink showed no growth. We obtained 3 AFB cultures, which were all negative. So the next aliquot will reveal the diagnosis. So let's see what you guys think.
Wow. Uh, each time I feel like, okay, maybe the next aliquot is gonna be more. Okay. So far, TB is less likely given the negative sputum cultures, the ADA being like low. Um, what else was like even no lymphocytes. So now I can see he has mildly elevated opening pressures, but otherwise the other lab indices were within normal. And then extensive infectious workup was also negative. A lot of some of the autoimmune diseases, for example, NMO, MS are out of the picture maybe, but I'm not sure the rare mononucleated cells and foam cells. I'm trying to yeah, I'm not familiar with this, honestly. So, trying to squeeze my mind, try to to make something out of it.
So while you're thinking, at least you weren't the one that said, "Hey, the repeat LP is gonna be noticeable," and then it was completely normal, other than the elevated pressure.
Um, yeah, I'm trying to think of what would the mononucleated cells be like. I think if I was seeing this patient, I'll probably be hopping on open evidence and try to see what does that mean at the moment. Well, maybe Jazz, you know.
I guess I actually never, I'll be very honest, I did not know what foam cells were either. I just Googled it, and maybe this might help you. And Sylvia, correct us if this is not correct, but it says on Google here, foam cells, macrophages with like lipid debris and can like so be seen any type of like tissue breakdown.
Sorry.
Yeah.
Yes, that's
So
exactly it. Mhm.
great. So, son, does that help in any way? No. Okay.
It is
All right.
helpful to try. It is, but not for me. I'm trying to think if now we should consider some malignancy or I don't know, honestly.
No, so this is a very hard case, and like I don't think, to be very frank with you, I don't know if we're gonna get the diagnosis correct, but I think we should focus on our journey, and I think we've made a lot of progress. I think after seeing what these foam cells were, thanks to the help of Google, I still want the MRI venogram. I do not. I feel like that could be from a prior tissue breakdown from like let's say clot. And if this is a cerebral sinus, a cerebral venous sinus thrombosis, that may potentially lead to these foam cells on the cytology. That hasn't been done yet. I'm not aware how good CTAs are. I know it, sometimes if it's bad enough, they can see it, but usually you would need an MRI venogram, which is this gold standard. I also wonder about a possible fistula still. Why we would have that? I'm just not aware of the cerebral sinus thrombosis causing leptomeningeal enhancement. So that makes me think about leptomeningeal malignancy, and maybe so son we're seeing the foam cells from that. Um, because that would explain the hydrocephalus, that would explain the diffuse cranial spinal leptomeningeal enhancement. And the glucose was normal, but like low normal. Sometimes you can see that neoplastic meningitis. Honestly, this is a patient that I would be sending like the biofire carriers testing. That's available in some institutions because yes, the AFP urine culture is reassuring, but sometimes PCR might be better to detect TB and some atypical infections. I'll be talking to my ID consultants about that. Um, I think so it's not like I think if everything comes back normal, we would have to find out that this might be idiopathic intracranial hypertension, but again, does not explain the leptomeningeal enhancement. So that's where I pause about that. So I think if to summarize, I would say ask ID if they can do a TB PCR to make sure this is definitely not TB, especially he has the endemic situation there. I am not aware of West Nile virus or anything like that causing this type of situation, so that's less likely. I would consider getting a MRI venogram to rule out clot, maybe a malformation. And then I would be getting flow cytometry or consulting my oncology team to see could this be a leptomeningeal malignancy like a lymphoma, leukemia, metastatic carcinoma, or a melanoma that may be leading to these type of findings, especially with the zero nucleated cells. So the zero nucleated cells tells me that this is not an active infiltrative meningitis, but it can be an infiltrated malignancy. But anything that came to your mind while I was saying all that, Sosan? If from all thing I said, what do you feel like? What are you leaning towards?
Honestly, I've learned a lot just from what you just said. There are a lot of like knowledge gaps that I had, but you're filling them. So thank you so much. Um, but I really like the thought of like involving both ID and oncology and try to figure out and the repeat testing for TB. As Valley mentioned, that diagnosis TB can be very hard
Yeah.
in such situations. So I'm excited to
Yeah.
hear more from Sylvia.
Amazing job, you guys. I'm really enjoying discussion. Honestly, anytime you guys are talking, I'm also learning things too. So it's amazing. So the next aliquot, we got given the concern, as you guys mentioned, rightfully so, TB versus malignancy, trying to understand what's causing the leptomeningeal enhancement. We got a CT chest, abdomen, and pelvis. which showed a 2.1 centimeter mass near the origin of the left lower lobe concerning for neoplasm, sorry, with possible liver metastasis. He then had a repeat LP a few days after, which did show malignant cells. He had transbronchial biopsy, which confirmed the diagnosis of non-small cell lung cancer. So there we go. You guys are close. Good job, everyone. Thank you.
Wow. Wow, Sylvia. This is such a great case with a lot of learning. Honestly, neurology is one of my weakest points, but I'm glad that I had to share this journey with Jazz. I've learned a lot from you, Jazz. So thank you so much. I truly enjoyed this journey and learned a lot. Great
So
job for the case.
So you paired yourself up with someone who also does his weakness is neurology. So I didn't set you up for that much success. But no, I kudos to you, So-san, for saying that, hey, this is a patient we may need to pan scan. And that was that was literally in the last aliquot. So good, you did a really good job. I know if when I was a resident, there's no way I would have discussed the case the way you did. So excellent job. And Sylvia, well presented, just the way you presented it and each aliquot had its own journey. Really well done. Thank you so much for being here.
Thank you so much again, everyone. Sorry, I just wanted to repeat. This is the way you guys walked through the case was amazing. It was so well walked through. The discussion was amazing. I know it was challenging for you guys the way it was challenging for us too. So thank you for walking through the case so well.
Amazing. I love it. Thank you so much, Jazz and Sansan, for discussing the case. I think you all did so great. And thank you, Sylvia, for presenting this case. It was, oh, sorry, the dog is here. It was a journey. I think we can open like for some questions for the program. Bettina, do you want to start sharing a little bit?
Yeah, sure. Yeah, so as I said, we are from Elmhurst Hospital. We are in New York, in Queens. I would say like the most diverse area in the whole world, meaning that we see cases like these. There's like a huge pathology, huge diversity of pathologies and a huge diversity of social issues that I would say like both of these things make you a really great doctor after you go through the training here. Um, and I'm joined here by my wonderful chiefs and my wonderful program director. If you guys want to say a few words introducing the program as well.
I'll just start. I just want to say one of my favorite things to do as chief or as a resident is just discuss cases. So it's so fun to come here and listen to other people's take on this case. This was very difficult. Sylvia had presented this as a morning report, and we had no chance at guessing what this was. But it's really fun to hear your thought process. So I appreciate you guys taking the time.
George, do you want to go next?
Sure, yeah. Hi, guys. I'm George. I'm one of the chiefs at Elmhurst as well. Thank you, Sylvia. It was a great case and a learning opportunity for all of us. And thank you for kind of leading us through it. Um, and yeah, we're a very diverse program, as Bettina mentioned. I think that besides kind of diversity of patients that we see, we also have a very diverse residency class. So we have people from like all over the world, and it's really fun kind of meeting everyone, meeting different cultures, and learning together and developing as clinicians together. So and thank you for Bettina for helping organize everything today. So.
And I'm just going to follow up what Bettina said by saying that uh, our patients don't just have an incredible variety of pathologies, but just they come with amazing stories. And I feel like, you can be on service for a couple of weeks and you can write a novel from the stories that you hear every couple of weeks. So really, I feel like our patients are absolutely incredible. And I want to give huge kudos to both Sylvia and the discussants. I think it was a really challenging case, and I did not know until we were kind of reading up on this case that the sensitivity of both the MRI and and cytology is so low, right? Sylvia, correct me if I'm wrong, but I remember it being something like 50% or slightly below 50%, which
Exactly,
is
literally 50 to
not,
60%.
which explains why the first MRI and LP were normal. And then even when the MRI became abnormal, the LP was still essentially normal except for the opening pressure. So really challenging. This was definitely practice changing for me because I think if I got two negative LPs, I can't imagine kind of, oh, well, if you get a third, then you pick it up, right? Um, I guess it just behooves us to know the sensitivity and specificity of the tests we're getting.
Oh, Samsung, do you want to read your question?
Yeah, I have a question regarding like how would you describe the balance between like autonomy and supervision that's given to interns in your program?
Can I take this one? So I think every program thinks and says that they have a great balance of autonomy and supervision, right? But I really do feel we have a great balance, and a big part of it comes from direct observation. So we have universal bedside rounds. You're spending something like 2.5 to 3 hours every morning in this very small group of and attending a senior resident, an intern or two, and a med student, and you're getting to watch each other and getting to know each other very well. And I think autonomy is not the same for everyone, right? There are going to be some things that, let's say, someone is ready for in November of their PGY1 year that another resident might not be ready till August of their PGY2 year, right? So it's not the same for everyone. And the only way to figure out what someone is ready for and when they're ready to kind of move on to more autonomy is to watch them, right? And the watching doesn't just happen. It's not a trickle down thing where like the attending watches the senior resident who watches the intern who watches the med student. Everyone is watching each other and learning from each other. And I think when you have such a tight-knit program and a very close relationship and very invested faculty who get to know the residents really well and residents who get to know each other very well, that's when you get true balance and true progression from autonomy, from supervision to autonomy at the right time for each skill and each task.
I had a question. So, residency, like as we all know, is very hard, and I think one thing that helps get through any residency program is like, how often are there like opportunities for the cohort of residents to get together and either have a residency sponsored social event or their own? Like, how often does that happen in your program?
I feel like I can take this question. I'm part of the events committee, so I'll happily take this question. We love hanging out, whether it's the program sponsored or not. I think it's very helpful in our program because we're all like really close knit and close friends. So it's like even just after work, everyone's like, "Oh, do you want to get food?" Like yesterday, we grabbed food, me and Bettina. Like it's just like little things like that because everyone's so close. You just always want to spend time together. I spent 12 hours in the hospital yesterday and I still went and hang out with Bettina yesterday. So it's just like little things like that. And even today we have an event sponsor, a program sponsored event. We're all going out together, doing something called a pub crawl, which one of our residents actually brought up to us and we're like, oh, this will be fun. So let's do it. So we kind of try to do it like every month. Everyone's open to like telling us what you want to do. Me and Bettina do poetry night and we invite people. We also do trivia night too and we invite people. So it's just like little things like that. We do big events. We had a barbecue over the summer, which I thought was amazing. And we also do little events too. And just it whenever anyone's able to show up, we're always happy to hang out and have fun. So yeah.
And on that note, I just wanted to thank all of our co-residents who are here right now. Thank you so much for supporting Sylvia.
Thank you. I'm just curious, any like favorite restaurants that the group likes to go to, like as a favorite?
Everyone loves Duzan. like everyone's like obsessed with this restaurant close by called Duzan. So I think that's definitely one of them. But Dan seems like he has another one.
We live in Elmhurst. It's the most diverse neighborhood. We have all of the best food that you want. We have excellent Thai food. I like Suriname. We have Ayaya, Angel for Indian food, and then we have like amazing momos, which we all love going to. Um, I like birria tacos. I'm from the West Coast, so I do miss my Mexican food, but we have some good exposure here as well.
And I'm going to say, if you go to our website, elmhurstmedicine.com, um, they're under, I think it maybe under Wellness tab, you'll see a map put together by our residents with their favorite eateries. But I will tell you, if you just go within like a block radius of the hospital, you'll probably see I don't know, 50 different ethnicities represented among the restaurants. And like that reflects the patients that we're seeing, right? You're going to see a Peruvian restaurant right next to a Nepali restaurant right next to an Ecuadorian restaurant right next to an Indian restaurant, et cetera, et cetera. So that's what our emergency room looks like as well. So, but if you want specific places, go to elmhurstmedicine.com.
I love it. And we always like to ask about POCOs. If you guys have a curriculum for POCOs, if George or Danielle want to answer this question.
Yeah. So we have the opportunity, we have these beautiful brand new like GE ultrasounds on every floor, and we really have started incorporating it more and more into not just our formal curriculum, but in our daily rounds. So we have a lot of new hospitalists and our home crit attendings who love using these and teaching with them. So they're really becoming like a stethoscope to us. We use them, we evaluate our new patients, and we're getting involved. We also have a formal curriculum, both in our ambulatory curriculum and one that we're slowly developing for the rest of the cohort because our prelims don't do ambulatory with us. So we do formal training, and then we have hands-on basically every day on rounds.
And from my perspective, because I am a complete POCUS imbecile, I just hope that I get to retire before stethoscope is completely outmoded and POCUS just replaces stethoscope because it's being used so much now that I'm just praying that we'll still continue to use a stethoscope for the next few years.
I think someone in the chat asked about sports that we like to play. I think there's a bunch of sports. There's like different group chats that we have for like sport activities. I'm in like a tennis group chat, so we sometimes go out and play tennis. I think there's like basketball, soccer, volleyball. We have like people who like to run, like Sylvia, you like to run, right? I think. I also am a runner. Dan also runs as well, I know. So I think we like it's like we have like a broad representation of sports that we and New York is great because you really have like a lot of free courts that you can use, but then also like you can easily rent like a tennis court and stuff. So it's pretty nice. Pickleball, also one that people like. I don't know if you consider that a sport, but I guess it's a fun activity.
Ouch! Ouch!
Like
I
it's
think
like walking and running, I don't know.
Right. I got a private message like asking about research opportunities in the program. I guess I can start and like George, I know you're very involved in research, so you can jump in after. But we have a lot of opportunities for research in our program. We have the research consortium that is basically we have a group for each specialty. Like we have a HEMOC group, we have a GI group. We also have a new like a hospital medicine group. So it's basically everyone who's interested in a specific specialty, you can all work together on research. You can work together in submitting abstracts to conferences. So we're all very active in research. We're all very supportive of each other. Each group also has a mentor to help you out with the research. And I'm also very proud to say that our program director is very involved as well. So every time that we submit an abstract, like she's always like she's always helping us out and always making sure that what we're submitting is really good. And she's always there like every step of the way. Yeah, so
Yeah, Bettina, you summarized it really well, but it's we're really I think we really in the last few years we really tried to kind of improve and increase the research output that we do as a program, and we have been really successful in it. This year we started a kind of an official research curriculum for all of the residents. And then, as Bettina mentioned, Research Consortium is a kind of resident-led initiative that gets residents together who are interested in research and really helps in that part of kind of career advancement. And we have access really to a lot of mentors within Elmhurst, but then also within like the Sinai system. So our residents are pretty involved in research, like various projects from case reports, retrospective studies, perspective studies. So if there's an interest, there's a way. So I would say we're pretty successful in it.
I'll just mention that we just had an annual staff meeting for all the attendings a couple of days ago. And for that, we had to add up all the abstracts that were submitted over the past year. And so we're a program of 79 residents, and we presented 114 abstracts at national meetings last year, which is, I think, pretty amazing for the size of the program. And I think that traditionally, for decades, Elmhurst was pretty famous for the clinical training. I feel like you can, you really have to like close your eyes and put your hands behind your back for 3 years in order not to learn clinical medicine at Elmhurst. But research is something that has become much stronger in the past few years, and thanks to George and some other residents who've created the research consortium and are making sure that it functions the way it should. And partly because the residents they're such a close-knit group, and they help each other and they kind of multiply each other's efforts, and the close connection to the Mount Sinai system, whether it's the main Mount Sinai campus or Morningside West, et cetera. I think connecting with faculty mentors elsewhere in the Sinai system has been really helpful for residents as well.
I just want to say, Dr. K, this is my first time meeting you, but I also had a program director that was enthusiastic, and I feel like you're giving me a lot of these enthusiastic vibes you hear on a Saturday with your residents. I think that bodes well with kind of what kind of leader you are. So I feel like yeah, just thank you for being here. And I think that was I can sense that from you, and from experience that made my residency experience a lot better too. So I'm sure the residents feel that way too.
Thank you for saying it. I love our residents. It's why I get up in the morning every day, and I love my job so much. And I think the residents are the reason for it. So thank you to my residents for keeping me enthusiastic.
We also love you too.
That's awesome. We have a question in the chat. Maybe I will go for Sylvia. Could you tell us more about the medical education track?
Yes, actually, I can do this to Bettina since she's in the track and will better explain it better.
Okay, thanks, Sylvia. So we have a lot of teaching opportunities in our program. First, just like, like casual, like micro teaching and like chalk talks. We do it all the time on our rounds. As mentioned earlier in our groups, when we do rounds, it's an attending, it's a senior resident, it's a junior resident, an intern, and then we also have a lot of medical students. So every time we do rounds, there's a lot of opportunities for teaching our juniors and our medical students. Apart from that, we do have the medical education track, and that is in partnership with Mount Sinai. So we have our residents from Morningside West, residents from Mount Sinai. So we all come together and we have like virtual like Zoom classes, I would say like each month, talking about like med ed, like curriculum development, needs assessment, and throughout the year, we use all of these concepts to formulate our own project, applying whatever we learned. And it's something that we're going to implement later on, like I would say like on the next year or so. The other thing is that we also have the resident teaching collective in our program. So that was started by one of our PGY3 residents, and it's been growing like a lot. So basically, what we do there is that we have weekly lectures for our medical students. So let's say I would be interested in teaching about hyponatremia. I could go and craft a lecture, like a 1 hour lecture, and talk about it with the medical students. If, let's say, Sylvia is interested in teaching about like leptomeningeal enhancement, like she can form like a 1 hour lecture about that and present it the next week. So we have a lot of medical students from so many different schools. And so it's a really, really great opportunity to apply everything that we learn in the med ed track. So usually we start the med ed track at like second year, and then we we continue that until the third year.
And I will just add that the med ed track itself doesn't have any teaching kind of opportunities built in as part of it, right? It sounds a little strange, but basically you're just learning the theory, right? And then you'll have the practice only as far as you're practicing it in your curriculum development when you're doing your capstone project. But the resident teaching collective is giving you the practice, right? So you get to teach medical students, and ideally someone will observe you, give you feedback, etc. So while you don't have to be part of one to be part of the other or vice versa, but together they really complement each other perfectly.
Amazing. And we have one more question. How does the program support the career guidance through the mentorship? Anyone that wants to answer?
Sorry, do you mind repeating the question? Was it mentorship and guardianship? Sorry.
Yeah. How does the program support career guidance through mentorship?
I can take part of this question. I think it's amazing how I know I keep bringing it up, but how much support we get. As we talked about the research consortium, that's also just one aspect. Like not just anything like that's set in place. Everyone's always ready to guide each other, not just like faculty resident mentorship, like between each other. I recently just became interested in oncology earlier this year, and I one of my residents is literally one of my mentors, Erin specifically. Like she really helped me, brought me into the research consultant, specifically oncology, has helped me with just getting research done, getting case reports out there. So I think just little things that not something that's very like strict, like, oh, I have to go speak with my faculty mentor. Even between each other, we have mentorship opportunities as well. She helps me with knowing which program, which specific cases to apply to, which present with conferences to apply to as well, helps me with knowing how to write, edits most of my papers as well. So I think it's just like little things like that just really outlines how much support we have in our program, which I'm extremely, extremely grateful for. And I know other residents also help each other through not even just calling mentorship, just helping each other. And even just from our program director as well, we can all speak to how amazing of a mentor Dr. K is. She'll take time out of her busy, busy day just to have a conversation with you, just to guide you with something. Even when I was going through switching different specialties, she really talked me and calmed me down and helped me realize like not everything is like set in stone. You're able to change and be malleable and move on to different things. And she'll always be there to support, and everyone around you also will be there to support you as well. So yeah.
Yeah, I also want to mention similar to like what Sylvia said. So besides the kind of informal peer mentorship that Sylvia was mentioning, we also the working groups in that are part of the research consortium. Each of them has a faculty mentor, so that's kind of the direct guided um, specific mentorship from a faculty that's usually a specialist within the field that the residents are doing research in or which research group they belong to. And then we also have formal, besides kind of the informal help and mentorship we get from Dr. Konevsky, we also have kind of formal semi-annual meetings where we really go over our career goals and life goals and both personal and professional goals in a span of like short-term goals, which is weeks, midterm goals, months, and then like years. So that happens really twice per year in every PGY year. So it is really a nice kind of official way to analyze how your success and if you're going in the right trajectory, and if your career is going in the direction you want it to go. And then we have really a lot of faculty, hospitalists and both subspecialists who do a lot of research projects and mentor our residents. So I would say there's a lot of mentorship going on at very different levels. So from peers to leadership in the program to faculty. So
Thank you for sharing.
I will just mention that the twice-year meetings are just absolute minimum, so that's kind of the safety net. You can't have any fewer than 2 meetings a year with someone in the program leadership, but for most people, it's a lot more meetings per year than twice a year, which is good.
I think we can ask for each one of you what is your favorite thing about the program, and this can be our last question. Regina, do you want to start?
Sure, I would love to. So my favorite thing about the program is the people, and there are a lot of reasons for that. I would say like I have incredible residents. Our leadership is amazing, led by Dr. K. I think really the theme of the program is that no one gets left behind here. Like we're all helping out each other. Everyone is so approachable. Even leadership is approachable. If you want to talk to Dr. K about something that's worrying you, like her door is open all the time. Another aspect of this is the patients, So I think, especially applicants this year, you're going to get a lot of interviews. Others are like other hospitals are better than others, but I would say like, in Elmhurst, like you really feel that there's a lot of like the diversity of pathologies is insane. So I think you will really fall in love with medicine, but at the same time, because you're getting to hear all these amazing stories, you're getting to see all these social issues, you're taking care of so many vulnerable populations that you don't just get lost in the medicine and you're always reminded of the humanity of medicine. I think that's the most beautiful thing about our program.
I think jumping from what Bettina said, honestly, my favorite thing is also the people, but not just even the people. I think it's the patient population we have. I've come from a background where, it's very less fortunate, very underserved, which is where I grew up. So coming here and knowing that I actually have the opportunity to help people who would otherwise go without help, who would otherwise, not have as much medical literacy or access to healthcare, and just knowing I get to actually help this patient population and like slowly actually seeing them get better, like following someone who was admitted and then they're following clinic with you, they're taking their medications, you're slowly watching them actually get better. It's such a very pleasurable experience. So I would say definitely just the patient population. It can be very tough sometimes, especially with like the language barriers, but as soon as you just make that amazing rapport with them, it really becomes such a fantastic experience. So yeah.
I cannot believe I have to answer after both of them. There's nothing more I can add. I think our residency, I just get to work with my friends every day, and it makes work so easy. You're here for long hours, and that's true of all residencies. But when you're having fun, when you're discussing cool cases, when you're with people that you love, the day goes really quick.
yeah, and I agree with what you guys have said, and I'll kind of add to that, which is kind of a similar theme. But I really enjoyed the diversity of the program, both in terms of the people we work with and the patient population, because I think that throughout training you really have kind of diverse experiences, and you get a chance to work with patients with really diverse problems and diverse backgrounds, and I think that makes you become a better clinician. And that experience you bring forward really helps you navigate any new situation that might seem kind of unfamiliar, but really you've had the experience during residency, because we are such a diverse place. So I would say that diversity you get throughout the training is one of my favorite things.
Yeah, I don't think I don't think I can say anything better than what you guys just said. I feel like our residents truly love taking care of our patients. They love taking care of each other, and they absolutely love learning medicine. And I feel like this enthusiasm about just medicine itself, for the sake of learning medicine, even when it's not connected to anything else in particular, is something that's very special. And I think it's part of what brings people to Elmhurst, because they know that if they're PGY1 or PGY31, they're going to see something today that they've never seen before. And it's really exciting.
Oh, amazing. Thank you so much for hanging out with us during the session. It was a great case. Thank you, Sylvia. Thank you for the residents, for Dr. K, for being here and spending time with us. We really appreciate, and we always have the doors open for you guys to come back and present more cases, as Bettina is the chief of our case review committee. So yeah, thank you so much, and I hope everyone have a great weekend.
Thank you so much for hosting us.
Thank you.
Thank you.